Thank you for joining us for the webinar tonight. ASPN will be talking about understanding advances in headache management. We are going to give everybody 2 minutes time to log on. We will start the webinar in 2 minutes. Thank you for all of you logging into the webinar tonight. We are going to start the webinar at approximately 9:02 Eastern, which is 6:02 Pacific, to give everybody time to log on. Welcome to our webinar tonight. We will be starting at 9:02 Eastern, 6:02 Pacific to give everybody time to log on. Welcome to the webinar. We will now begin the program.
Well, thank you very much, and thank you for joining us tonight as we go through into our 5th month of webinars. Since we began in March, we've had about 7,000 unique individuals join us here for these webinars, and certainly tonight is really important because I always tell young residents and fellows, I think 2 of the hardest things to treat in our field is pelvic pain and headache pain. And certainly we've struggled with those problems for years, and we're making some grounds in pelvic pain, but we haven't really had much in the way of education for our members on headaches. So tonight we've put together an amazing group of experts to really teach you some of the finer points of headache management. So let me introduce my colleague, Dr. Krishnan Chakravarthi, and he'll take over with the introduction to the faculty.
Thanks, Tim. So I think you made a really pretty direct, pertinent comment yesterday. We were saying that, especially in the COVID climate, a lot of us are now starting to manage, a lot of interventional pain docs manage headache that traditionally we've had the ability to refer out to neurologists. And I think to that sentiment, this group of faculty, I think, really are absolute leaders across the country, have published a lot on different guidelines on both medication as well as approach and interventional, non-interventional approaches. So Dr. Schuster's out is a faculty at UCSD. Dr. Baird, who a lot of the fellows probably know, is a program director at Stanford, and Dr. Christensen is at OSHU, and Dr. Argoff and Dr. Piliplis, who don't need any introduction, have done a lot in this space, are coming from Albany. So I'm going to let, kind of going over, they're going to start with the approaches, they're going to cover medication, talk about non-invasive neuromodulation stuff as well as interventional stuff, and we're going to do Q&A with the faculty. Just one comment for folks that are on, you can certainly put your questions out in the chat box. Dr. Deere and myself will try to get the questions over to faculty as time permits, but really want to make this as interactive as possible. So with that, I have the pleasure of introducing my close colleague and friend, Dr. Schuster, who I work with at UCSD, to talk to you about approaches to headache.
Excellent. Thank you, Krish. So here are my disclosures, and today I'm going to be presenting my simple approach to headache, a 6-step approach that you can use to deliver high quality care to any headache patient. First step, evaluating for secondary headaches warranting further evaluation with a Snoop screener. The second step, identifying the primary headache disorder using ID migraine, and then screening for medication overuse headache, especially important in the pain clinic, and then delivering treatment. Preventive, also known as prophylactic treatments, acute, also known as abortive treatments, and lifestyle treatments. So first of all, what is a secondary headache versus a primary headache? Very briefly, the secondary headaches, these are the things that we're very afraid about, things like tumors and bleeds, and that in my experience are very uncommon to come to the pain clinic, but important to screen for. And then the primary headaches, this is what we're mostly treating. So far and away most common is going to be migraine. Tension type cluster headache are much less common in the pain clinic setting. So screening for secondary headache disorders, starting with the two S's, systemic symptoms and secondary risk factors. So systemic symptoms, so if the patient's been having fevers, night sweats, weight loss, or secondary risk factors, so if they're immunocompromised or if they have a history of cancer, you need to evaluate for and think about the possibility of an infection or metastasis in the appropriate setting. And so for that, consider an MRI in the appropriate setting with contrast. If the patient's having neurologic signs, so an asymmetry on exam, well, you have to think about a mass lesion or a stroke and would order an MRI. For a headache in starting after the age of 50, uncommon, concerning for secondary causes in general. And one important one to think about is temporal arteritis, or if they're having amaurosis fugax, so a curtain dropping over their vision in one eye, jaw claudication, thinking about temporal arteritis, evaluating starting with an ESR and CRP. So onset thunderclap, thinking subarachnoid hemorrhage. These patients do not come to the pain clinic, they go to the emergency room. So the 4 P's that I use are positional. So think about intracranial hypertension or hypotension. Hypotension, you're all familiar with, spontaneous or iatrogenic. Intracranial hypotension, so a headache that comes on with standing, goes away with lying down. One that I don't want you to over-test for, very importantly, and this goes together with the next P for papilledema, is idiopathic intracranial hypertension, also known as pseudotumor cerebri syndrome. Very uncommon. We all learned about it in med school, thinking about it in young, overweight women, which is a population where migraine and chronic migraine is very common. So rather than thinking, oh, we need to do a lumbar puncture, what I would certainly recommend, first do an MRI, possibly an MRV, and obtain Humphrey visual fields, so non-invasive testing. Because if you don't have papilledema and if you don't have peripheral vision field loss, it's probably not going to be pseudotumor cerebri syndrome, and you're going to cause a lot more post-dural puncture headaches than you are going to catch cases of IIH. So don't overstate the need to evaluate for pseudotumor cerebri. And then primary headache different. So what this means is that if the quality is different, so it's not that they're having more frequent headaches or more severe headaches, but the patient who comes in and says, "Doc, these headaches do not feel like my typical migraines." And then the last one is pregnancy. So causes of headache in pregnancy include preeclampsia, cerebral venous thrombosis, and pituitary adenoma, and if they bleed into it, apoplexy. And so how to evaluate for that? With blood pressure and urinalysis, MRI with pituitary protocol, and possibly with MRV in the appropriate settings. So this is screening for this using the Snoop screener. You don't have to memorize this because when you're in clinic, you have a computer in front of you. You can always just Google it. And what you're going to find if you Google Snoop headache is a lot of people have put different slides, just like mine, online that you can use to go through your Snoop screener in clinic. So for identifying the primary headache, and this is the most important thing that we do, well, there's this big Bible of headache conditions, the ICHD-3, that you can always check online, but we're going to be going through today, most importantly, banging home the importance to not miss the diagnosis of migraine, because as you're going to see tonight, there are so many effective treatments for migraine. It's incredible, and it's high prevalence. 18% of women, 7% of men, 6% of men in any given year are going to experience migraine. So don't miss the horse, thinking about zebras. And so if you're going to ask just 3 questions to screen for migraine, the 3 questions you want to ask are the ID migraine validated screener. So with their headaches, do they get nausea? Do they have photophobia? And are their headaches incapacitating? Are they limiting their ability to work, study, or do what they need to do? If 2 of those 3 are positive, you have a sensitivity of 0.81, specificity of 0.75 for migraine. And so the quick mnemonic I use for this is PIN, photophobia, incapacitating, and nausea. And so in pain, we talk about acute pain versus chronic pain. In migraine, we don't use the words that way. It's acute versus preventive treatments. It's chronic versus episodic migraine patient populations, where chronic migraine is when patients are having at least 15 headache days a month and at least 8 migraine days a month. And in chronic migraine, as you're probably familiar, well, that's when Botox is indicated, but also incredibly importantly, that's when you need to be screening for medication overuse headache. And so this is where when people slip up and they miss the migraine diagnosis, I think it's because when you're thinking with the pain mind of the importance of description and location of pain, that actually in headache patients, this is much less important. Much more important are the associated features, whether they're having migrainous features, whether they're having autonomic features. And so I receive referrals all the time of men with headache being referred as cluster headache who end up being migraine. It's important to remember that migraine in men, 6%, cluster headache, 1 in 1,000. So 2 orders of magnitude more likely for a man who comes into clinic to have migraine than to have cluster headache based on epidemiology alone. All the time, trainees hear vice-like or squeezing headache and they think tension type headache. But if those headaches have photophobia, incapacitating, nausea, it's still most likely to be migraine. Likewise, bilateral. Don't let that trick you into thinking that it's going to be tension type headache. Because if the patient's coming into a pain clinic, tension type headache, these patients most often do not seek medical attention. So bilateral can still be migraine if it has migrainous features. Likewise, occipital headaches, if they're having these associated features, it's still most likely migraine. And neck pain, in one study, 75% of people when they have a migraine have neck pain with their migraines. And so everybody here is really great at identifying and treating for the cervicogenic parts of a headache. But if they're having photophobia, incapacitating, and nausea, don't forget about thinking about what the role of acute treatments to treat their migraines when they occur, preventive treatments. So don't want to think that just because there's neck pain that it's not migraine. And likewise, stabbing pain behind the eye. Sometimes people think, oh, that must be cluster headache. But if it's having light sensitive, if it's having photophobia, incapacitating, or nausea, it's still much more likely to be migraine. And when I get referrals for sinus headache, and this has been in the literature, more likely than not, it's going to be migraine once again. And as I said, with cluster headache also, so many of these patients end up actually being migraine. So another pitfall that sometimes I see people falling into is thinking that response to occipital nerve block, well, then it must be occipital neuralgia. But in fact, in many randomized controlled trials have been performed in the emergency room setting as well as in the outpatient clinic setting, occipital nerve blocks are effective for treating migraine. So that does not make it occipital neuralgia. And in fact, these are studies where they weren't screening based on occipital location or occipital tenderness. They were just doing it in all comers with migraine. And so the differential that we all learned in med school of primary, and is important in the primary care setting, is migraine versus tension type headache versus cluster headache. But actually in the pain clinic setting, the chronic daily headache patients are who we tend to be seeing much more often. And so the differential for chronic daily headache, 1 through 4 is what neurologists are taught about: chronic migraine, hemicrania continua, new daily persistent headache, and chronic tension type headache. And then as you all who work in pain clinics know very well, there's also cervicogenic and occipital neuralgia that you're all wonderful at diagnosing and treating. So I'm going to quickly run through the other ones that you might not be so familiar with hemicrania continua. So very importantly, it's not just that it's a headache on one side of the head, it has autonomic features on that same side. It never switches sides, one side always unilateral pain, autonomic features, and it's incredibly responsive to indomethacin. New daily persistent headache. This is a headache that starts one day out of the blue and goes there on out unabated in somebody who doesn't have a prior history of headache. And unfortunately, this is a very treatment refractory condition with no known effective treatments. Maybe somebody on this call will figure out that neuromodulation can be the answer for these patients who are desperately in need of an effective treatment. And then the very least common actually of these is chronic tension type headache. While episodic tension type headache, incredibly common, chronic tension type headache is actually very uncommon. And more often than not, when I see it, it's because of medication overuse. Okay, and for time's sake, we're going to move through some of these, but some of these slides will be available at the very end for you all as a QR code. Okay, so two other important differential diagnoses to be aware of. One of them, the headache that awakens somebody from sleep. Another one, headaches that are provoked by Valsalva, cough, exercise, and sex. Well, all of these, they need to be evaluated for secondary causes with MRI. And these are patients who you might want to refer to neurology for further evaluation. So now that you've gone through identifying primary headache disorders, we now come to medication overuse headache, incredibly important. If a patient's having headaches more than, or they're using their acute medications more than 10 times per month, triptans, ergots, opioids, or combination analgesics, so those including caffeine, such as Excedrin, or those containing butalbital, such as Fiorcet or Fiorinol, or in the case of acetaminophen or NSAIDs, using them more than 15 days per month, that you need to consider that actually it's due to a rebound headache or medication overuse headache that their headaches have become more frequent, and that actually addition by subtraction, that by getting them to use those medications less or stopping them, that their headaches could go back to being less frequent. And so now, wrapping up the simple mnemonic, you have preventive or prophylactic treatments. You have the acute or abortive treatments. And then you have your lifestyle treatments. And one of them in particular here that I want to point out is, I tell patients all the time, avoid the modifiable identified triggers that you can, but don't blame yourself. Don't try any elimination diet that you're told about, that not all migraines have a modifiable trigger. And that's why we have our preventive treatments, and that's why we have our acute treatments for these patients. And last, and you'll have access to a bunch of these slides as part of a QR code. This simple tool that you can use when thinking about what I'm going to deliver a patient who tells you, "Doc, I've tried everything, there's always more things." So if it's a patient in the episodic migraine column, these are the acute and preventive treatments to think about. If it's a patient in the chronic migraine column, these are the acute and the preventive treatments that you can think about for them. And with that, these are my references. And here is a QR code with some references that you can bring back to your clinic and your trainees. I'm available for questions.
So Dr. Schuster, that was a great talk, and certainly it was a lot of information. I think we'll all go back and review your slides and learn more. I just have a very quick question for you, and it's quick, but you could go for an hour, so I just want you to give me kind of a summary. We get people all the time sent to us on 2 or 3 hydrocodone a day from their family physician with severe headaches that are often occipital. We tried occipital block, it doesn't really help. Now we have a patient that we're stuck with these opioids, and they get the rebound headache, as you pointed out. What's the best workup for that person, and what is a good way to transition from that opioid regimen, which was inappropriate to begin with, to a better regimen?
Yeah, absolutely. And thanks for that question. So actually, the federal government's investing $7 million into looking at this question, how to treat medication overuse headache, run out of Mayo Scottsdale. And so what they are doing are randomizing patients to a few different strategies. Until we know the results of this study, the approach that I bring is I tell patients we're going to add in some preventive treatment. So whether it's things like botulinum toxin, CGRP monoclonal antibodies, the different preventive treatments that you're going to be hearing about in the next talk, as well as giving them medications for acute treatment that are non-opioid. And I tell them, try to use these first. and use those opioids as little as possible, as infrequently as possible. And ultimately, hopefully, once we identify effective acute treatments for you that are non-opioid, not using those opioids at all. So rather than telling them, and this is what a lot of neurologists might say, just get the opioids out of the picture and you're going to get better and you won't need preventive treatments. My personal approach in my practice right now is I'm going to give you preventive treatments. I'm going to give you non-opioid acute treatments, and then we can have you not using those opioids anymore.
No, that's very helpful and great answer. Thank you so much for a wonderful talk. Krishan, you want to introduce our next speakers and we'll move on to the next topic. Krishan, you're on mute.
Yes, there we go. So next we have Dr. Barrett and Dr. Christensen that are going to actually walk through all of the current medications that are in the market and also stuff that we actually haven't heard of, some of the newer ones. I think really be impressed with some of the data that's been coming on this topic. So I'm going to invite Sandy to come on and talk us through this.
Thank you, Krishnan. So the first thing I want to stress as an interventional pain physician is a lot of the reason why we get referrals for headache management in our pain clinics is because medications have failed. So the traditional oral preventative agents for migraines, the statistics are unfortunately not in patients' favor, and there is no agent on the market that has performed better than 50% in 50% of patients in clinical trials. The number needed to treat one patient successfully for a migraine is between 4 to 6, meaning 4 to 6 patients need to receive that agent in order to have a successful result. The other thing that I think is always important is understanding kind of where our patients are coming from. As interventional pain physicians, we're not always prescribing headache medications, but it's good to understand kind of what patients have already been tried on by either their primary care doctors or their neurologists. And so this is kind of a easy pathway that any pain physician can understand in terms of what patients generally have tried before they land in our pain clinic. And you can see it's listed in terms of the first line agents. And then what this algorithm recommends is generally doing a 2 to 3 month trial. If the patient is either not tolerant of that medication or has side effects to that medication, trying another first line agent. And then if none of those first line agents are either available, tolerated, or helpful, then in that box at the bottom is a whole list of other treatments that could be tried. So the key points for any pain physician, is make sure patients have tried at least a 2 to 3 month trial. Can I get a slide back, please? Make sure patients have tried at least a 2 or 3 month trial and then document that in their record. And then if there were any intolerances, in order to get other therapies, sorry, slide back. In order to try any other therapies, it helps to document what the intolerances were, and then also document basically how long they tried those medications. I found that to be particularly helpful with getting Botox approved and the CGRP antagonists approved. So the real question is even though that's the algorithm for basically how patients should be treated with their migraines, the question I always pose is, does it really make sense when the number needed to treat is so high to start with those preventative medications, because they do seem to fail? Unfortunately, for all of us, that's often not our choice. And what we all know all too well is that insurance generally doesn't approve more invasive treatments like Botox or neuromodulation unless patients have basically a documented failure to those medications. I will mention too that even though the recommended trial is 2 to 3 months, if you document that the patient is intolerant or the medication is contraindicated, you can bypass that, but documentation is very important. And then again, the first line agents that are recommended are the propranolol, the timolol, amitriptyline, Depakote, sodium valproate, and Topamax. The side effects to these medications are unfortunately pretty common. 1 out of 5 patients treated with any of these oral migraine preventatives will have a side effect that leads to discontinuation. And then, you know, side effects aside, the overall compliance with these therapies is unfortunately 1 out of 4 when the patient's taking it for 6 months, and 1 out of 5 when treatment duration increases to a year. And so, you know, for one reason or another, maybe people just don't like taking pills, the compliance is low. So that brings us to a topic that we're more common with, and I'm just going to touch on this briefly because my colleague will go into this in much more detail, but many of us get referrals for Botox for migraines. The problem with Botox for migraines is not only that you need excellent documentation in order to get it approved, and basically what that documentation needs to entail is that the patient's either had a 2 or 3 month trial of at least 2 to 3 different oral medications that are in that first line class. But the other thing is that Botox for migraines is not shown to be effective for episodic migraines and thus only approved for the chronic migraine category. The CGRP inhibitors that my colleague will talk about in more detail in a moment here do have both abortive and preventative formulations, but unfortunately those aren't considered first line either, just because they're very new. They're still costly. There's no long-term safety data, and there's a lack of comparative data. The last thing I wanted to mention, which Nat touched on, is in all of my documentation, I always make sure to document the absence of a medication overuse headache. And this is something that I ask all of my patients for in terms of what are they taking in terms of their NSAIDs on a monthly basis, like how many days out of the month, any combination pain relievers, triptans, opioids, caffeine use. So anything more than 200 milligrams per day is associated with a rebound headache. And what that equates to is about 2 cups of brewed coffee, 5 cans of cola, or 1 energy drink. And so the other thing that I've found to be helpful in terms of getting approval is making sure that this is well documented, that the patient does not have a component of medication overuse. And that's not just for insurance purposes, but it's also to help, you know, basically make sure that the treatment that we're gonna now start has the best chance of working, because if you have a component of medication overuse headache, you can cause a treatment refractory headache, or it can lead to treatment failure. I'm going to pass this on over to my colleague now.
Great. Thanks, Sandy. Hopefully everybody can hear me. So as Dr. Schuster already said, and Sandy alluded to, prevention is indicated for more than 4 headache days a month, a preventive medication choice. And then an acute medication is not to be used more than 10 days a month. So we're kind of trying to ride a fine line. I'm going to go a little bit more in depth on some of the newer medications that have come out. Okay, so just to review the AAN guidelines of our level A medications that should be offered, as Sandy said, Topamax, Depakote, and beta blockers. Our level B medications are tricyclics, essentially, and level C medications are basically many others that there just isn't enough evidence to not enough large scale trials, so they should be considered. But we haven't had many new medications on the market since those guidelines were written, and now we're entering a new phase of the monoclonal antibodies. So this is a picture of arenimab. This was the first CGRP, calcitonin gene-related peptide monoclonal antibody to come on the market. In the next picture here, we'll talk a little bit about the mechanisms. Calcitonin gene-related peptides are were discovered by identifying the fact that CGRP, which is located chiefly in the primary trigeminal afferents. And when you give a migraineur CGRP, they have a migraine attack, but it does not happen in healthy controls. They also have noticed that CGRP serum levels are elevated during attacks, and that there is decreased CGRP in the plasma, and that corresponds to decreased pain after a patient is given a rescue medication. So there are many lines of converging evidence that led to focus on this peptide. And after some serial different drug development, they came along with the monoclonal antibodies. There are 4 currently on the market, and the most recent one was approved in February of 2020. The benefit of these medications, as Sandy was saying, many of the oral medications have so many side effects and are so difficult for patients to tolerate. These have many fewer side effects, chiefly because they don't cross the blood-brain barrier in high concentrations. Because they're not metabolized by the liver or the kidney, they're metabolized by the reticuloendothelial system. And then they're much easier to take because they have such a long half-life. So it's either monthly or quarterly dosing. So imagine going from having to take a pill 3 times a day to a monthly injection. It's really a new era in migraine preventive treatment. The drugs have some differences. For example, erenumab targets the CGRP receptor, while the other 3 target the peptide itself. There's some differences in the humanizability of the antibody, and there's some difference in the doses. They're all sub-Q with the exception of Vyepti, which is IV. Erenumab has 2 doses, 70 milligram or 140. Galcanezumab actually starts with a loading dose of 240 milligrams, so it's 2 individual injectable 120 milligram cartridges. They also have a second indication for cluster headache, and so that's what that 300 milligram dose is. Ajovy and Vyepti are dosed quarterly, or Ajovy can also be dosed monthly depending on your preference. So you have different options there. Okay, so moving on to the next slide. All in the outcome studies, which I've shown here, all of these drugs showed statistically significant superiority over placebo in their main measure, which is a decrease in monthly headache days. So as Sandy alluded to previously, many of our oral preventives had a small response rate, a small responder rate. It was considered a big win if 50% of the patients, had a 50% decrease in their headaches. And that was really the metric that we measured this by. But now we're seeing a higher 50% response rate, as you can see in this fremanezumab trial. 60% of the patients had a 50% decrease in their headaches versus placebo. You're also seeing that there is a 75% response rate. So some of the studies looked at this metric, and then some of the studies also looked at the 100% response rate, which is really remarkable. Not all studies looked at it, so we can't say if it occurred in all studies. But for example, in this galcanezumab study, 11% of the patients, their headaches were gone, just gone. So that's, again, a very remarkable finding, which gives us a lot of hope that we're on to something really exciting for migraine prevention. Okay, these studies also focused, these were very big, very well-designed randomized controlled trials that paid closer attention to quality of life which is something that they borrowed from the pain world, having previously focused on something called a MIDAS score and a HIT score, which are rather limited measures of functionality. They've expanded to include more patient-related outcomes, which I think is interesting for us as pain providers, because we use patient-related outcomes a lot to measure our patient success. All right, and how do you know as a provider if you should start your patient on a MAB? There have been some guidelines given by the European Headache Foundation and the American Headache Society on how to integrate these new treatments. And many insurance companies are kind of following these guidelines. So basically what they are looking for is patients with episodic migraine or chronic migraine. And that's an important point I want to make, is that any type of migraine is indicated for these MABs. Patients who have tried and failed 2 or more preventives or cannot tolerate preventives due to comorbidities can be candidates for MABs. And what should you do with your other preventive medications when you're using MABs? It's a little bit, there's some different options, but in general, it's okay to continue oral preventives. Botox probably should be stopped. However, there's not any interaction between MABs and other oral medications, or any interaction between MABs and Botox. So there's no real right answer to this question. You should reassess after 6 to 12 months. American Headache Society says reassess after 3 months to see if you're having any meaningful impact. And which patients should not use MABs? I think it's important to recognize we have very little information on pregnant or nursing patients, people with cardiovascular disease, or alcohol or drug abusers, probably not good candidates for MABs. Okay, so quickly, where does Botox fit in? Botox is still a very important part of our treatment plan. As Sandy said, Botox is indicated only for patients who have chronic migraines, so more than 15 days a month. The American Academy of Neurology came up with a revision to their guideline in 2016 that said that it should still be offered as a treatment option to patients with chronic migraine. There's level A evidence that it can increase their number of headache-free days, and can reduce their impact on health-related quality of life, reduce the headache impact on health-related quality of life. So there's very much a role for Botox, even with the introduction of MABs. Okay, next slide. Now moving on to acute medications. There's 3 new acute medications on the market that I wanted to talk about tonight. But before I go there, I just don't want anybody to forget about the classic tried and true triptans, which are the rescue medications that we have used up until now. These are still very good medications. And in a 2015 systematic review of 133 randomized controlled trials, they found that pain relief at 2 hours with a triptan ranged from 42 to 76%. That means your pain's not totally gone, but it's relieved, it's down a good notch. And 2-hour pain freedom, meaning your pain's totally gone, ranged from 18 to 50%. So these are still very good drugs, and we shouldn't throw them away entirely. But if you cannot take a triptan, you've had a bad side effect of the triptan, you've had a stroke and you're worried about the vasoreactivity of the triptans, then there are several new drugs to consider. I'm just going to skip through this for the sake of time, but these are the different formulations of the triptans. I'm happy to make these slides available. The new meds on the market are threefold. So first one is called lasmiditan, and lasmiditan. This is a class of medications called the DTANs. They're 5-HT1F receptor agonists. They come in 3 different doses. No more than 1 dose should be taken in 24 hours. Now, these this drug crosses the blood-brain barrier, so they can cause some impairment, and you have to advise your patients not to drive or operate machinery until at least 8 hours after taking a dose. Side effects: dizziness, sorry about the spelling error there, fatigue, paresthesia, and sedation. Time to absorption, about 2 hours, so a little bit of a longer time to absorption, and average half-life is 5.7 hours. And it is a Schedule 5 drug like Lyrica, so it does have to be put on a triplicate, and that's again because it crosses the blood-brain barrier. All right, so again, looking, if you guys remember those numbers from triptans, we see pain freedom of Rayvow about 30% at 2 hours. And then we see a new metric, which is called your most bothersome symptom. And that's something that they're looking at, which seems to be photophobia for most patients. They wanted, about 40% of patients said that they were free of their most bothersome symptom at 2 hours. And those were the big metrics that lasmiditan looked at in their study. Ubrogepant was the next medication to come to market. This is an oral CGRP receptor antagonist. So we have some CGRP monoclonal antibodies, and now we have a small molecule oral CGRP receptor antagonist. The dose is 50 or 100 milligrams taken orally, and similar to a triptan, if needed, it can be repeated after 2 hours. Not to be used with CYP3A4 inhibitors, peak plasma concentration 1.5 hours, same type of half-life 5 to 7 hours, which is longer than most triptans. They usually have a half-life of about 2 hours. Pain freedom at 2 hours, 19%, 21%, not startling, but the most bothersome symptom is approaching 40%. Pain relief at 2 hours, so knocking it down a notch or two, is about 60, 61%. So that is similar to triptans in terms of pain relief, but maybe a little bit less than triptans in terms of pain freedom, depending on the triptan. And finally, the last one is Rimigepant, Nurtec, and this is an oral dissolvable tab. Pain freedom at 2 hours was 21%, pain relief at 2 hours, about 60%. And so I'll let you guys decide what the best one to use is, but at least we have more options. Thank you.
So for just before we move on, I think Tim and I have one quick question a person. So, you know, I think for a lot of folks that are, especially fellows, don't get a lot of experience around pediatric pain, and this becomes a very important topic, especially with a lot of headache management in that demographic. In maybe a very short kind of summary, does it really and you guys have shown a lot of different drugs and different approaches. Is it that much different in terms of the younger age group in terms of this type of management, or do you find that it's kind of the relevance in terms of the algorithm applies there too? Either one of you guys can take that question.
I don't treat pediatric patients, so I'm gonna punt this one to Meredith.
There's very few studies that have looked at these drugs in the pediatric population. So you cannot get Botox approved for the pediatric patient. Some triptans have been approved. Topamax and tricyclics have been approved, but the MABs haven't been studied in the pediatric population yet either. I'm sure they will be because their safety profile is so good in adults, but it hasn't happened yet. So for kids, we're kind of left with the basics. We haven't really advanced into the newer treatments yet.
I have one quick question as well. You know, we get people all the time that we're treating with the neurologist. You know, they're sent to us for cervical facet ablation, they're sent to us for occipital nerve stimulation. But, you know, the question for me is, you talked about, you know, and for either one you want to answer this, but I think Dr. Brad, you talked about this a little bit in your talk. So they're on a CGRP antibody treatment. And you said, I think you said you couldn't use Botox with that. So is it not proper to use those two together, or can you use those two together?
I think it's fine. The challenge is the insurance. So
Okay,
I think
okay.
that's the biggest issue right now that I'm facing, is that if my patient wants both treatments, insurance is saying you got to decide.
Pick one. Okay, gotcha.
Yeah.
I
But
have
no, I
not
don't think
been
there's
able
any
to get both
contraindication.
covered. Yeah. I don't have a single patient I've been able to get both covered. And so what I have to document is, you know, we're no longer going to do Botox, and instead we're going to do the CGRP antagonist, and then I can get it covered.
Yeah, and usually we're getting those people who are failing the CGRP somewhat, and we add Botox to it sometimes and get it approved. So it might be the situation of the algorithm or the the treatment. So well, thank you both so much. That was a wonderful talk. I think it's a lot of information. I look forward to going back to the slides myself and going over them again, because you presented so much data. So with that, I greatly appreciate it. And so we're going to move on to Charles now. So there's an old Japanese saying, fall down 7 times, stand up 8, Charles. And I've watched this non-invasive neuromodulation for the headache code for years. And 2 people I've listened to the most, Peter Stats and yourself. And you've taught me a lot about it so far, but I'm sure tonight you'll teach me even more. And so with that, we'll give you the distinguished professor, Dr. Charles Rogoff. So Charles.
Well, thank you, Tim and Krish. And now for something different, right? So this is really an exciting area, and I'm going to briefly provide an overview of non-invasive neuromodulation. And I hope that I can advance things. Okay, these are my disclosures. And this is what I hope to accomplish. So it is going to be a brief overview. I'm going to briefly propose mechanisms of these devices, and I think it's important to review the clinical evidence. And I think that, oops, let me go back. Can you go back one slide, please? There we go. So there are many different ways to approach neuromodulation or devices for migraine and headache disorders. And I'm going to be concentrating on several in this slide that are non-invasive. And there's some really exciting new data about those. So we're going to be talking about transcutaneous supraorbital nerve stimulation, which is known as a Cephally device. We're going to be talking about vagal nerve stimulation, which is known as GammaCore, Sapphire. And we're going to be talking about transcranial magnetic stimulation. And we're going to be talking about remote electrical activation. So it's a very exciting time. Next slide, please. Next slide. Thank you. So here are some examples of the devices that are available. And we'll be talking about the Nerivio device. This is the remote electrical device that's used. The GammaCore device is the vagus nerve stimulating device. The important thing to think about is, how does neuromodulation work? And we're all very familiar with the gate control theory of pain, in which we understand that a non-nociceptive sensory fiber can stimulate inhibitory interneurons, and nociceptive efferents inhibit them. So an increase in non-nociceptive input will reduce the rate of firing of the spinal thalamic tract neurons and then dampen pain. And so how can we utilize that? So let's look now. We're going to be showing, I'm going to be showing you data regarding the remote electrical neuromodulation, or REN device, which is what Nerivio is. And this, as opposed to transcutaneous nerve stimulation, which we're all familiar with, doesn't work in terms of mechanism of action on ascending pain inhibition. It works on descending pain inhibition. In this instance, using a remote, and I'll show you a picture of this in just, I showed you in a second, but I'll show you again. You're actually activating CNA delta fibers. So you're activating nociceptive fibers from a remote pain location. This is what's so cool about this. And ultimately, you're activating descending pain inhibitory fibers to turn off the pain, in this case, headache. And so this is what we have learned through years of studying, is known as conditioned pain modulation. And the Nerivio device capitalizes upon this in trying to help somebody avoid a migraine. This is someone who I work with, who is using the Nerivio device today, not because I caused her headaches, but because she had a headache. So now, conditioned pain modulation, we're going to go over some mechanisms very quickly. Again, as opposed to you're actually activating descending pain inhibitory circuits by turning on pain. And ultimately, you're dampening the pain information by turning on A delta and C fibers. And this is done through application of an electrode to your arm. This is attached to a cell phone. It's wireless to a cell phone program that runs the programs to stimulate the individual so that this conditioned pain response can occur. Very cool and very easy to use. This is a very busy slide just to point out that there are a number of different non-invasive migraine treatments, and I'm going to go through them in a little bit more detail. We know about transcranial magnetic stimulation. I'll come back to that in a second. With vagal nerve stimulation, actually stimulation of the vagus nerve may modify cortical excitability. The device that is now available that capitalizes upon this is called GammaCore Sapphire, and it has actually been indicated, it's FDA approved and indicated for 4 indications. That's right, 4. The preventative treatment of migraine headache in adult patients, the acute treatment of pain associated with migraine in adult patients, adjunctive use for the preventative treatment of cluster headache in adult patients, and the acute treatment of pain associated with episodic cluster headache. So those are a number of indications that for this particular device. This is the Nerivio data, and Nerivio, this is from one of their pivotal studies. And as you've seen already, it's a wireless remote electrical neuromodulation device, and this is now approved for the acute treatment of migraine with or without aura in patients who are 18 years of age or older and who do not have chronic migraine. And you can see 48-hour or 2-hour post-treatment responses. You can see the differences between those who experienced pain relief, 60, more than 2/3 compared to those who received a placebo or sham activation, 38% pain-free, 37.4% versus 18.4%. You just heard Dr. Baratz talk about medication kind of pain freedom rates, and this is certainly so novel and so interesting that you can achieve this with a non-invasive device. 48-hour sustained pain relief, 39%, and pain-free, 20.7%. So really respectable data. This is a study, one of the studies involved in non-invasive vagal nerve stimulation for acute therapy for migraine. This is a study of 248 patients with or without, with acute migraine with or without aura. And vagal nerve stimulation was superior at several time points compared to sham, but not all. And you can see how this is applied to your neck in a non-invasive way. This is the Cephally device that you may have seen or had your patients. This is a 109 patient study with acute migraine with or without aura who are randomized to receive this device or sham during an attack for 1 hour. And migraine with aura did not reach significance, but migraine without aura was superior to sham for pain-free at 1 hour, but not 2 or 24. This is an older study of single pulse transcranial magnetic stimulation for acute migraine, which also showed benefit. This is not something that I think many people actively use these days, but another device that has been shown to be beneficial. So in conclusion, one of the interesting things about everything that's been presented so far is that most of the patients who we treat with a particular preventative agent, monoclonal, Botox, don't have 100% pain relief. And they're sometimes struggling, even with the available of abortive agents, what else can be done? And so this non-invasive device approach is a very promising area. There are multiple available, and it really remains to be determined how they can be optimally utilized in both an interventional practice or even a non-interventional practice. So thank you so much.
So Charles, wonderful job, as I expected you would do. But I have a question for you. So let's say you're in a practice like mine where we do occipital stimulation, but there's not been optimal devices, but there's better devices now for peripheral nerve. But obviously this is a great attractive choice for patients who have non-invasive options. How do you get started? I mean, how would I start a program in a practice in America where you're doing mostly interventional therapies? And we think this is interesting in the future, and I think vagal nerve in general is very fascinating to me. So how would I start a practice of being non-interventional therapies like this?
I'm not going to teach you how to run your business because I think you've been pretty successful. But I would say identify a champion in your practice, or anyone who's ever listening, who's really going to take a lead. So the person who you saw, Carrie Tram, who is permitted me to show her today, she really took a lead in getting interested in when we identified someone who was interested in these devices in our practice. And Julie and I try to integrate our practice as much as possible on a daily basis. But when Carrie took a real interest, and so when we identify a patient, Carrie sees them and knows how to make it work. You know how important it is in a practical world to make it work. And so these devices, so some, you know, one may work. There are many to try. And so it's important to have a lot of tools in your toolbox. I showed 3 that are commonly being used, and having someone in your practice who really can understand it and talk about it and facilitate it is really important, because you know a little bit of this is trial and error.
Oh, absolutely, great advice, Krish.
No, that was my actually similar question. I mean, I think there's so many people out there. I'm getting a bunch of texts being, that's a fantastic talk. How do I implement this? So I think those are really valuable. I have, you know, we're lucky that Dr. Schuster actually is at UCSD, so we have that internal referral. But I think a lot of it is also knowing what's available, and I think that lends itself to making better referrals. So.
Let me ask a question before we go on to our last speaker, Dr. Politzis. Let me ask a question of Dr. Argoff. So Charles, are you going to make it so that we don't need Julie's therapies going forward, or where are we going to be with non-interventional therapies in 10 years? Is it going to be so good that, you know, we really don't need to be interventional anymore for headaches or head and neck pain?
I think that we're going to be practicing truly holistic care and using what's best for each individual patient, each individual person, and we're all going to be very, very busy doing what we like to do.
No, that's great insight. So our last speaker, before we go to just a final few questions in the last 20 minutes or so, we have about 20 minutes to go. And our last speaker is certainly a world-renowned figure in the area of both neurosurgery, but also in the area of functional neurosurgery, which I find to be very fascinating. So Dr. Julie Politzis is going to talk to us about her work and working together often in concert with Dr. Argoff. So Dr. Politzis.
Thanks so much, Tim and Krishnan. Those were my disclosures. Some of those were STEM related. And you know, I'm not going to talk about any specific product in this talk. Michelle, I think I'm just going to have you advance my slides. So starting with our treatment algorithm, Charles and I are very lucky, similar to Nat and Krishnan, to have each other to work with all the time. So, you know, I think the first crux depends on, you know, what we've been learning about today, which is coming up with an accurate diagnosis. Not all headache is migraine, similar to how not all facial pain is trigeminal neuralgia. So you need to work with a team to identify that as such. Of course, when things respond to medication or a lot of the great options that we have, you're going to do that. Botox has become increasingly common. Sometimes we'll do sphenopalatine ganglion nerve blocks as well. And, you know, when things are refractory, that's when many of us on the line get contacted, either to start with non-invasive neuromodulation, and sometimes those can be a little bit more cost effective and but sometimes temporary, similar to how we use a TENS unit as opposed to an internal device. So there remains a refractory group of people who can benefit from neuromodulation. The 2 big things that are used for neuromodulation in this area are occipital nerve stimulation and high cervical stimulator trials. Of course, you're going to trial these similarly to what we do for any kind of trial, and with greater than 50% relief, go on to permanent implant. Next slide. So occipital nerve stimulation, as we all know, the greater occipital nerve and the lesser occipital nerve innervate the back of the head. You know, when we're learning how to do blocks, you feel where that occipital notch is and target in that routine. And when you're putting a stimulator in place, you want to make sure to get as much of the nerve covered with that stimulator as possible. You can get coverage with occipital nerve stimulation almost to the front or the hairline in some people. And then what happens in a subset of people is supraorbital stimulation may be an option. So again, when you're learning how to do this, feel your face in terms of where that supraorbital notch is, and you know when you get it because it tingles. And so stimulating that area is also an option. Next slide. What's the data? There's been several studies, and I think as with anything in pain, when you say, think about when we call something back pain, that encompasses so many different things. So again, achieving the right diagnosis for migraine is absolutely essential when you're thinking about neuromodulation. This is one of the cited studies looking at ONS for chronic migraine, and unfortunately, a lot of the studies in this arena haven't met endpoint, which has made coverage of these systems from an insurance standpoint difficult. Sometimes we wonder, and we can always Monday morning quarterback about what is our outcome measure, and this differs in the headache literature than it does in what we're typically used to looking at, and we're talking about reduction in headache days, as well as disability and pain relief, and then not just reduction in pain relief days. I think it's really important, like when we use NRS, to say, okay, what's your NRS right now, but what is it at its worst, what is it at its best, and learning how to reframe those questions and kind of getting a composite feel about the patient is absolutely essential. Next slide. So this is the technique that we use. I typically will go in the midline for my permanent implants. I like this needle that you're able to bend with the plastic stylet, especially for ONS type procedures or supraorbital procedures for that matter, just because you can follow the curve of the scalp. It's important when you're doing these procedures to identify the fascia and to stay on that fascial plane. If you get too high or too high above that and near the skin, people complain of a kind of pinching, ticking, stinging sensation. Another thing that you learn from your mistakes, make sure you prep out widely so that you can see the tip of where that needle is going. If you don't do that, you can pop through the drapes and not realize that that's even happened. Next slide, please. Sometimes we use these in concert. I think we forget when somebody comes to us for neuromodulation sometimes that this is just meant to be one tool in our toolbox. We do the same when we're treating migraine. So, just because you have a stimulator in doesn't mean that you're going to be off medications. It's treating the patient as a whole. And it's particularly exciting as we consider the synergistic effects of some of these things. So, this is a patient of mine that has both systems implanted, and that may be helpful. Next slide. Supraorbital stimulation, this can be helpful. This is tricky, however. It used to be when you were talking about peripheral nerve stimulation, because this is has historically been off-label uses of devices used for percutaneous lead placement, that there's a really high migration rate. You can get around that, with some experience and some tips and tricks, so that it's greatly reduced. Supraorbital is harder still, just because you have to ask for so much of this device. It has to go in this area in the forehead where you don't have much tissue, so it can tent up the skin, and that can be problematic. There can be erosions, and then it has to travel a long way down to get wherever it's going. So multiple skip incisions in areas for wound breakdown. So just because somebody wants a little bit more, make sure the patient really needs that before considering this adjunct to your system. Less is more in these cases, and the majority of times you can get a really great result with just occipital nerve stimulation alone. Next slide, please. this is, our life is trials and tribulations of trying to get things that help patients covered by insurance. And if you're not aware of this, Jen Sweet and I and a bunch of functional neurosurgeons that are my closest friends published this guideline in terms of ONS for occipital neuralgia. We're talking about migraine here, but as a reference for peripheral nerve stimulation, these are some guidelines that may be helpful to send along to insurance companies should you be fighting denials. Next slide. What's new in PNS? Really similar to what's new in SCS. We're looking at different waveforms. We've tried high frequency, we've tried burst. Most interesting, both from the clinical and preclinical data, it doesn't appear that the high frequency, when used in the peripheral area, is causing a block, or at least a complete block, which is different than what people thought. It is interesting, in terms of following people with burst as well as high frequency out longer. You may see some quantitative sensory changes over time. So, we still need some data on this, but it is promising. Next slide. We're getting better devices. So this is one option, which is a wearable stimulator attached to a wire placed through the skin. It can last as long as 60 days. A lot of things we do are geared at breaking the pain cycle. And, maybe this is long enough in certain cases. This device has shown some promise. Next slide. Rather than our large IPGs, there are devices that are now FDA approved that no longer have that large IPG. So look at the size of the devices on the left compared to what we're used to implanting, and you can see in these teeny spaces, like where the occipital nerve is or the supraorbital nerve is, how this could be very helpful. Next slide. So in conclusion, we have the great non-invasive options that Charles spoke about that are helpful in certain patients, but we also have implantables that really do a great job if the patients are well selected. I'm really excited about what's coming up next. I've seen Konstantin Slavin present this on this topic many times, and I've been waiting for some of these devices to come to the forefront, and they seem to finally be here. Thank you very much for your attention.
Julie, that was a great summary of what's going on. And what we're going to do now, we're going to bring everyone back to join us, and we're going to spend about 15 minutes just for what we call rapid fire. So very quick answers to questions. And the first question I'm going to give to you, because we're getting these from the audience. And so the question is, and again, some of these you've already answered in your talk, so we're not going through those. But Julie, when you put in a cervical simulator, okay, and the question is, I've done a lot of lateral high cervical simulators. Do you do them percutaneously? If so, what's your target in the spine to help headaches? And if not, do you do a retrograde paddle from C1 to downward?
Yes. So I put them both. In the cervical spine in particular, I'm partial to percutaneous leads. It's just a much more invasive procedure to go retrograde. There's a lot of muscle wasting, and if you didn't have a headache before, you might have one after. So I start with a percutaneous lead. I'll drive that up as high as I can get it. So when I do my occipital nerve stimulators, I'm at the level of the DENS or the arch of C1, and try to get as far up with that cervical lead as I can as well.
Oh, great answer. Chris, your question.
Yep. So this is for Dr. Argoff. One of the questions that came up is, for the non-invasive devices, has there been any assessment on maintenance of efficacy or therapeutic durability with these devices, and any comparison on that?
So I'm not aware of any long-term studies. I think that's a great question. I'm not aware of any long-term studies, like 52 weeks or greater. I don't know if any of my other colleagues are aware of long-term data. That's a great question, and we should have an answer to that.
So great. You know, that's a great non-answer, but I think it's pretty accurate. So I appreciate that. The next question is, and you may all see this. So sometimes people think it's a high cervical facets causing pain, and they do a cervical rhizotomy, which we do a lot for mechanical pain in the lower cervical spine. But the patient sometimes develops a severe neuritis, and the neuritis is actually worse than the original pain. So when you've had people do either pulse rate frequency of the occipital nerve or DRG or cervical joints, what's your recommendations for neuritis after some form of destructive procedure for anyone on the panel?
I think whenever you're considering that, you know, I think there's such a hard, sometimes you have such a hard time getting these covered. You know, they say, doc, just bring me back and burn it, cut it, do whatever. And, you know, I always caution against that, just because of what you report. You know, we know that people are probably going to feel great oftentimes for like 6 months, and then it'll come back either as it was or even worse as you're talking about. And then you have a really hard problem to solve. So I guess in my non-answer, try not to cause it in the first place, because once it's already there, you know, you're kind of behind the 8 ball.
Great advice, although not always able to follow that usually. So, but that's really good advice. So Chris, you get one question. I'll do the last question. So we'll go from there.
This is for Dr. Schuster, Dr. Barrett, and Dr. Christensen. So one of the, and I know especially because Stanford has been a big proponent of ketamine infusion. Any thoughts on use of that for migraines? Any data to support, not support? This is one of the questions from the audience.
I don't know of any great data to support use of IV ketamine infusions for migraines. Nat, Charles, we'll try it for a medically refractive
treatment. For acute treatment, they've studied intranasal, and that was not effective. What little evidence there is for IV use is from Jefferson, and just sort of suggests that it's something that can be used as part of your treatment for patients who are electively admitted. And certainly that's been what I've been hearing from patients is a lot of patients saying, hey, you know, it's the best that I've felt for 24 hours, which I think is what we've heard for a lot of chronic pain conditions. So I think it's part of when somebody is admitted as for an elective admission to detox them off of a medication that they're overusing or to get them out of a bad cycle, that can be used together or in place of things like IV DHE. But as monotherapy, it hasn't been studied. Certainly, I think that's one place for it to be studied. Another place is in the emergency room. I know my colleagues at UCSD have been trying it in the emergency room and have had good anecdotes to keep people from needing to be admitted, to get them out. And that's another place for it to be studied.
We also just add that. Oh, sorry, Tim.
No, go ahead. I was gonna
add that there is a study published recently in anesthesiology that I found quite interesting. And it was a small study. I think there was only 20 patients, but it looked at ketamine infusions for pain and long-term outcomes. And by long-term, it was just a month or 2, or maybe even 3 months. And they said it wasn't helpful compared to placebo. So interesting article, very recent in anesthesiology if you want to look it up. It didn't specifically mention migraines, but just pain conditions.
So the only thing more popular than ketamine right now for everything that has no evidence oftentimes is marijuana. So the last question for the panel is marijuana for migraines and headaches. What's the evidence? Is there any evidence for that? Whoever would like to start.
So I was going to say,
yeah, exactly.
Yeah, I was going to say, Dr. Schuster,
there isn't evidence yet. Come back and ask me in a couple of years, and hopefully we'll have some evidence. We're doing a study at UCSD, hopefully kicking off in the next couple months, where patients are going to be randomized to receive, in a crossover study, THC versus THC CBD mix versus CBD versus placebo, treating one migraine with each of those 4. And we're going to see how effective it is in the acute setting.
Great. So here's the last thing I want you all to do for us in 30 seconds. We have a bunch of fellows and people going into pain practice watching this talk tonight. You all did an amazing job. So give us a pearl. And, you know, based on my screen, I see Julie at this end, and then I see and Nathaniel, then I see Charles and Meredith and Sandy. So I'll start with Julie. Give us a pearl that people take home about treating people with head and neck pain. Give us a pearl for that to end the session.
So so this is just kind of a technical nuance. When you're putting in ONS, make sure that you anchor it at multiple points where you've done that. And then as you come down to wherever you're going to put your battery, make another strain relief loop. Don't be scared to use extensions if you need them. You just want to have a lot of slack in that system.
Great.
Yeah.
Okay. Ask every patient you see whether they have photophobia, nausea, whether it's an incapacitating headache. For all, I think, talking about the efficacy rates, people might not have been completely overwhelmed by some of these that really, these new medicines have improved the lives of so many patients with less side effects. And if you don't ask about migraine, you're not going to be able to get patients those treatments.
Dr. Argoff?
Don't expect one treatment to do it all. So always have a plan B or C and do it in a seamless fashion so your patients don't think you're giving up on them.
Great.
The fifth most common symptom with migraine is neck pain. So do not come and tell me that your patient has just neck pain, just occipital neuralgia, without asking all the migraine questions similar to what Nat has, because common things being common, it's much more likely that your patient has migraine, which 10% of the American population has, than any other cervicogenic syndrome.
And I would say make sure your documentation is very clear in terms of how long patients have tried medications, what was the reason for failure, any side effects, any indication of medication overuse headache. And then if you're switching between expensive treatments, make sure to make it clear that you're stopping one to initiate another. It'll help with insurance coverage.
So great pearls from all of you. Thank you so much. I learned a lot tonight. Certainly I'll go back and review your slides because some of them were too complicated for me. So I'll go back and look at those. But thank you all so much. Christian, you want to take us home here with the final comments?
Yeah, I mean, I echo that sentiment. I feel like these webinars, as much as for us learning as well as us moderating these sessions. So really a heartfelt thank you to all the faculty. You guys do an amazing job every time, putting a lot of effort. And I think hopefully a lot of the fellows that are on tonight and those that will be listening to this will get a lot of positive feedback and education from this. So just for the audience, we've got a bunch of more stuff coming up from Aspen. We're going to be doing the virtual think tank and then follow on to our annual conference that's coming up. That's going to be all virtual. So look out for these dates. I know we've been very active in trying to get these dates out on social media as well as through different email chains. And we really are going to try to get a lot of the CME credit. But I think tonight, if you can appreciate this, we're really trying to make a broad appeal to all the folks that are in pain medicine, whether interventional, non-interventional, and headache. And I think that's just wonderful that we've seen such new faces, new faculty, as well as folks that have been really leading this field for a long period of time. So really an honor to have you guys all on. And Tim, I'll let you say the last words.
No, I just want to thank everyone, wish everyone a healthy end of the week and a weekend, and hope to see you again in the next few weeks. Stay safe out there, everyone. God bless, and good night.
Right.